All right, does that look good to you all? Perfect, great. All righty. So a little bit more about me. Like I said, I graduated from Ithaca College, which is it's in central New York in the Finger Lakes in 2022. One of my really, really close friends from college is actually an admissions counselor at Davidson now, which is how I had this connection. But I majored in health sciences with an emphasis in clinical genetics, and I also had a minor in counseling. Like I said, I'm a second year student at UNCG, so I'll graduate in May. And I've completed clinical rotations in pediatrics and cancer genetics. And right now I'm in a non-clinical rotation. So every student is required to do one non-clinical rotation, regardless of what program you're at. And so mine is in leadership development. So I worked with one of my professors to create it this semester. I was also a graduate assistant at UNCG, and I am finishing out my term on the executive board for the Student and New Graduate Special Interest Group for the National Society of Genetic Counselors. I've given this presentation probably 10 times, and each time I've had to change this last bullet of what I'm actually interested in. Right now, I think I can safely say I'm interested in anything that's not prenatal genetics, but yeah, so I'm not too picky, and I feel like I might have a similar journey to you all because I came straight from undergrad, which is becoming less common, I think, with genetic counseling master's programs. So first off, to get us all on the same page, let's talk about what exactly genetic counseling is. This is from the National Institute of Health. It's just an allied health provider who provides information and support about genetic risk and diagnoses. There are three critical functions of genetic counseling that this is one framework for thinking about it, but assessment, education, and counseling. So assessment is gathering information through medical intake, drawing out a family tree and a pedigree, which some of you all might have seen before, and assessing whether or not someone's at risk for a genetic condition or whether we're suspicious of a genetic condition running in a family. Education is providing information to a family or patient about either a diagnosis we're suspicious of or that has been confirmed via testing. We also educate people about testing, so letting them know the types of results they might get, the way that testing works, the implications of those results, those kinds of things. And then psychosocial counseling is also a really big part of genetic counseling. So we provide a lot of psychosocial support, whether that be through, sort of in an appointment, one-on-one, talking about things, or referring to community resources or social work in the hospital system that you're working within. But just to help people adjust to these diagnoses in what are often, pretty hard circumstances, or at least complex circumstances for families. So the thing that got me into genetic counseling, or originally drew my interest, was this idea of non-directiveness. So I'm someone who is very passionate about patient autonomy, and that's something that I think genetic counseling also really, really values. So in recent years, I think this label non-directiveness has been called into question of, if we never tell people anything about what to do, that's not good either. But in general, genetic counseling really values autonomy, and there are limited instances where a genetic counselor tells someone that, like, this is the test you need to get today. A lot of times it's talking through the situation with patients to help them reflect their values and what's most important for them at this moment. And if that is getting genetic testing, say they are actively in a cancer diagnosis and genetic testing will help inform treatment, then of course we're going to be a bit more directive and encourage that kind of testing. But if it's something that a patient doesn't seem like they're super interested in, a genetic counselor is rarely going to push for it, and sort of tell a patient that that's something they need. So for someone who is really passionate about patient empowerment and people having control over their own healthcare, this was a big factor for me in choosing this field. And then some job stats. So these are a year out of date now. The new professional status survey came out this year, and I haven't been able to get a hold of that yet. But as of 2022, 9 out of 10 genetic counselors are satisfied with their job. The average salary in 2022 was $102,000, just about. The average starting salary in 2023 is about $83,000 to $84,000 now. And genetic counseling is a growing field. This says there's a projected 26% growth rate from 2020 to 2030. But there are some sort of legislative efforts that I think if those are successful, that 26% might be even higher. So it's a field that still has a lot of growth going on, and there's more and more specialties coming about every year. So now that we know a little bit about genetic counseling, how does one become a genetic counselor? So to apply to school, so first of all, you need to get a master's from an accredited program. And to apply for admissions at a master's genetic counseling program, there are 3 main categories of experience that you need. The first one is exposure to the field. This typically comes through shadowing a practicing genetic counselor. The National Society of Genetic Counselors, or NSGC, has a Find a Genetic Counselor tool where you can specifically select for people who are open for student contact and student interaction. So a lot of times it's just cold emailing those GCs and asking if they would be willing to have a student shadow them. You can also do informational interviews with GCs. Let's say you email someone, they say, you can't shadow with me because of the limitations of my institution, but I'd be happy to get on the phone with you and we can talk about it. Those are also really helpful. Some sort of advocacy experience. So in undergrad, I worked for an institution that provided respite care for families of children with disabilities. So specifically, I worked with adolescents with Down syndrome in making social-oriented goals and then like accomplishing those goals by doing community outings and things like that. But there's patient advocacy roles, there's sort of non-healthcare related roles, which sort of ties into crisis counseling. So some sort of experience with crisis counseling is, I wouldn't say required, but really, really encouraged. So some people will work for like women's advocacy centers on some sort of hotline, or the crisis text line is really popular. But those kinds of experiences, because often some of the news that we are giving in genetic counseling is not desired news, to say the least. And so having some experience with sort of high intensity situations can be helpful. Research, I think, is less emphasized in these 3 things, but can also be helpful. But I think that the most important part about doing research for the purpose of applying to genetic counseling schools is to make sure you're able to reflect on that experience and tie it into genetic counseling. So my research was on the gut microbiome of mantled howler monkeys. So not super, super related to human genetics, as you might imagine. But I was able to talk about presenting at symposiums and breaking down information into a non-science understandable manner. So those things are really important. And then if you know about medical school and residency applications, you might be familiar with this match system. It's relatively new for genetic counseling, but so when you apply to schools, you'll get interview invites. Some schools will do 2 rounds of interviews, some schools will just do 1. And then after the interviews, you rank the schools that you've interviewed at in order of which you'd prefer to go to. And each school will have different scholarship tracks, and you reach each of those tracks individually. In the meantime, the schools are doing the same thing with all of the students that they've interviewed. So the number of students interviewed really varies by school, but I'd say from experience, it's often like the 40 to 100 sort of range. And so they're ranking all of those students. And then this algorithm, the match, takes both of those lists and matches you to a school. So everyone finds out on the same day if they got into school and if they did, where they're going. And that result is binding. So you don't receive more than 1 acceptance. You receive 1 acceptance and like, that's where you're going. If you match and you get a school that you don't want to go to, you can like pull yourself out, but then you're often barred from applying for 3 to 5 years. Just because like you basically, by applying and registering for the match, you're agreeing to follow whatever result you get. That's why a lot of times people will say, if you don't want to go somewhere, just don't rank them at all, because if you match there, you're going to need to go there. And then what actually happens in a master's program? So all programs have the same 3 core components because they're required by the accrediting body. So that involves didactic coursework, which is lectures, what you're probably familiar with in undergrad. Depending on the program, those might be broken up into sort of more full days. So instead of having class 5 days a week our first year, we have class on Tuesdays and Thursdays, but those classes are from like 9 to 5, Tuesday and Thursday. Your capstone or thesis, so depending on the program, they might have more stringent requirements. Some of them might require sort of a traditional master's thesis, where some require a capstone, which means you can do research or you can do some sort of creative project. And then rotations. Typically rotations start like rotations where you are seeing patients and involved with the process often start the summer in between your first and second year. Some programs will start earlier, but it's more of an observational or just family history kind of experience. And we're all required to have a rotation in cancer, pediatrics, and prenatal. And then depending on how many rotations your program has, you can have some extras thrown in there. And you also have to have a non-clinical rotation, like I mentioned. Typically programs are 2 years full-time and in person, but there are exceptions to every one of these rules. So off the top of my head, Johns Hopkins is 3 years. There's a couple new part-time programs that have been announced within the last year. There's a couple virtual programs. There's a couple of programs that are dual human genetics PhD and genetic counseling master's degree. So there's a lot of variation in there, and there's, I think, 50 something programs now. There's always 2 or 3 programs trying to get accreditation each year, so the number changes, but vast majority of programs 2 years full-time in person, but obviously there's exceptions to that rule. And then, as I've alluded to, there are sort of 3 main specialties in genetic counseling, but tons and tons of other options as well. So again, this is dated from 2022, but in 2022, cancer was the most common specialty, with just about half of genetic counselors working in it. And then prenatal had 36% of genetic counselors, and pediatric had 29% of genetic counselors. But like I said, tons and tons.
I have a question about that.
Mm-hmm.
So is that the percent that are in that field, or does that correlate to like the need for cancer, pediatric, and prenatal?
Yeah, so I think there's a survey that goes out to genetic counselors that are members of the National Society of Genetic Counselors every year. So this is just like, this person said they were in cancer and X out of 3,000 people said that. I think that it is, for hospitals, it's sometimes easier to justify cancer genetic counselors because cancer is just so prevalent in the population, right? And so I think that there sometimes can be like more cancer jobs available just because it's easier to justify those things. But these percentages are just like, out of the 3,000 people that took this survey, these are the people that indicated they work in cancer. Tons of subspecialties. So some that came to mind when I was making this are metabolics, ophthalmology, cardiology, neurology. Some GCs just specialize in rare disease. Some GCs are research genetic counselors. So there's tons and tons of options. And depending on which specialty you go in, I'm thinking like ophthalmology and hematology. There are either clinical trials or FDA approved gene therapies in these areas. So the specialty that you're in might have an impact on the kind of care that you provide as well.
Can I ask a quick question?
Yeah.
Would you elaborate some on what like a research subspecialty would look like?
Yeah, so I think there's different options. Like obviously there are genetic counselors that work for programs, and like I have a research coordinator for the UNCG program, but there's also genetic counselors that will be involved in these clinical trials for gene therapies. So they'll be the ones getting informed consent from patients, providing the counseling for patients in these gene therapy trials. There's also, I read an article for a journal club last year that genetic counselors are more and more often being used in non-genetics research because we are trained so well at obtaining an informed consent that a lot of translational research efforts are actually hiring genetic counselors now, even outside of the genetics realm.
Thank you.
Of course. Alrighty. So I have just a brief slide on each of the main 3 specialties to give you an idea of what they each look like. So this first one, prenatal genetic counseling. Prenatal GCs see expectant parents who are at an increased risk of their children having a genetic disorder or teratogen exposure. So teratogens are just sort of environmental exposures that may impact a pregnancy. There's also preconception genetic counselors who see couples before they've gotten pregnant. But some of the common indications for prenatal genetic counseling are Down syndrome or other aneuploidies, which are just differences in the number of chromosomes someone has. This is, as you might know, more common with mothers that are over the age of 35. So a lot of genetic counselors will see people who are either at risk just because they're over 35 or because they've had some sort of screening or testing that's shown that they're at risk of a genetic condition in their pregnancy. Differences in sex development or other ultrasound findings that are atypical from what we'd expect. And then, like I said, environmental exposures, which could be like drugs or alcohol, but could also be certain medications or work exposures, things like that. Then pediatric genetic counseling. Pediatric genetic counselors see patients of all ages, but typically, most commonly from around birth to 20 years of age. I say all ages because adult genetics clinics are sort of uncommon. So a lot of peds genetic counselors will see adults who have an indication other than cancer or prenatal. Generally, some of the indications seen there are birth defects, chronic disease, developmental delay, and intellectual disability is very common, or differences in growth. So either someone's not growing as much as we think they are, or they're growing really fast unexplainably. But those are some of the common things for peds. And then cancer. These genetic counselors see patients or families with a family history of cancer. So more cancers than we'd expect on one side of the family, early diagnoses, rare cancers, things like that. Or a personal diagnosis of cancer at an early age or a rare cancer, something like that. Cancer GCs can help coordinate with treatment teams. So often cancer GCs will attend tumor boards, which is where sort of an entire oncology team at a hospital will get together to discuss patients. And cancer GCs also sometimes help differentiate between somatic versus germline testing. So somatic testing is testing the cancer tumor, which will have a different genetic profile than the person themselves, and trying to figure out, is there anything in this tumor that makes us suspicious of a germline or something that's just in this person's entire body mutation that's caused them to have an increased susceptibility to cancer. My slide's not changing. Give me a second. Sorry. Okay. Well, that's actually a good stopping point because this is where I was going to stop for questions. If anyone wants to know more about anything we've talked about, if you have questions I didn't answer, I am all ears.
I have a couple of questions, so I'll jump in. Okay, one thing I mentioned when you were talking about like the experience, I had a couple of questions about that. So for like shadowing, is there a recommended number of hours for how much you should shadow a genetic counselor?
So I've never heard a specific number thrown out. I was applying immediately following COVID, so I actually didn't have any shadowing experience, but I think that's pretty atypical. now that hospitals are more open to having students around. I think the number of hours might be less important than what you're able to say about those hours. If you're able to speak and reflect on them in a way that's really meaningful and shows that you've learned something, I think programs will be less interested in saying like, well, this person has 400 hours of which is unrealistic, hours of shadowing. Because if that person isn't able to speak about it, it doesn't really matter.
Okay, awesome. And then I just have another quick question. So I do like the crisis text line, and so were you saying we should do crisis counseling and some other form of advocacy, or would that like that volunteering count as kind of that avenue?
I think it could, based on what you're able to talk about. I think having some exposure to a patient population of like, even if it's not genetic, like people with cancer or children with developmental disabilities or XYZ, having some exposure to that, but specifically in a more healthcare oriented setting might be helpful. A lot of people get involved with patient advocacy organizations. Like, I'm trying to think off the top of my head, like the Huntington's Disease Society of America is really active in North Carolina. I'm trying to think what else. There's tons. They're just not coming to mind right now. I apologize.
Yeah. Oh, awesome. Thank you. And then, okay, someone else can ask. I have more, but I can wait later because I don't want to take up everyone's questions.
I kind of have a question. I'm interested in how like your personal experience with figuring out what you wanted to specialize in and like the challenges with that and sort of just what that process looked like.
Yeah. So I came into graduate school thinking I was going to be really, really interested in prenatal genetic counseling. I'm very passionate about like reproductive rights and justice and things like that. And I was like, this is going to be the hill I die on. I'm going to work in this forever. And then I've had such amazing experiences with my peds and cancer rotations that I've been like, geez, this is really challenging that belief for me. So I think a lot of it comes from experience. I think also what it'll come down to is what jobs are available in the next couple of months. I think that might be a bigger impact on what specialty I end up in than any like desire that I have. Sometimes people say that you can choose your location or your specialty. I don't know how true that is or how not true that is. It's just what we've been told. But yeah, I think the experiences you have in rotations are really impactful. You'll have a lot of guest lecturers your first year that work in those specialties. So like listening to them and getting an idea of what their day-to-day looks like. Do they see patients every day, or do they do a lot of clerical work and for research purposes, or are they going out and having meetings with patient organizations? There's a lot of difference. And so learning from people who are currently working there has been the most illuminating for me.
I can ask another quick question if no one else has one. And you may talk about this later, but I was just wondering, I have like done research and I was planning on trying to do research again this summer, but I was wondering what you kind of did for your summers to like get experience for this, because I don't know if there's other things I should be trying to do instead, if that makes sense.
Yeah. My summer and winter breaks, I worked full-time as an orientation assistant at my undergrad. So not related to genetic counseling whatsoever, but I was able to speak about, working with at-risk students or first-year students who are really struggling with the transition to college and like providing some informal counseling in those situations. So I think working with people or working with something related to genetics would be helpful, but I don't think it necessarily needs to be both of those. I think as long as you're able to talk about what you've learned from the experience, that's going to be the most important. I have classmates, a lot of my classmates, or not a lot, 2 out of 9 of us, which feels like a lot, were high school teachers before they came to our program. I have a classmate who was a videographer for 6 years before he decided to switch careers. So I think it's less about what you do and more about how you speak about it.
Thank you so much.
Of course. I'd like to keep at least 10 minutes for our case studies, but if there's any last question.
I have a question.
Yeah.
You mentioned earlier the website to find like shadowing positions. Would you be able to like repeat it or like send it in the group chat?
Yes, I will put it in the chat now. If you just look up the National Society of Genetic Counselors and then find a genetic counselor. When in like the filters of the search bar, there will be a button that says open to student contact. So just make sure you click that, and then you can put in location or specialty, or if you know someone, you can find their contact information. And then you can email those people and see if they allow students to shadow.
That's great. Thank you, Maddie. All right, we better pivot to our case studies so we have time for Amanda at 11:45.
Yeah. So do you all have, I have 3 of them prepared, one for each of those main specialties. I'll say I've done the pediatric one like 8 out of 10 times. So I feel like I can run through that super well. But if you are interested in one of the others, I am more than happy to do that one. So do we have a preference for prenatal, peds, or cancer?
Yeah, I'm very interested in prenatal. So if we could touch on that, that would be awesome.
Of course. So
Thank
I've
you.
got a couple of slides that will talk about like the indication, and then I'll give y'all some time to create a differential diagnosis. So that's just a list of things that you think this could be. So here's our indication. You're seeing a couple who's been added to your schedule as an urgent add-on following their 20-week anatomy ultrasound. So in case you're not familiar, at around 20 weeks, people have an like the in-depth ultrasound that looks to make sure that everything's looking all right. What kind of information do you think is going to be most helpful when you're trying to think of how to quickly prep for a patient who perhaps you don't have as much time as you usually do? Like, what are the things that you really want to know? Okay, I'll start then. I think one, what were these ultrasound findings? If you read through this slide, you can see it on the next one, but what were the ultrasound findings? Why am I seeing them, right? Is this their first time presenting for prenatal care, or have they had regular prenatal care up until this point? Are there any exposures that we know about? Is there any known family history, things that we can figure out before we see them to potentially talk about? So you look in the person's medical chart and you see that the ultrasound has shown an increased nuchal translucency, which is called NT, and some sort of kidney anomaly. They haven't written exactly what it was. And typical female genitalia was reported. So nuchal translucency is a measurement about like the back of the neck. But I'll tell you, both of these things are what we call soft markers, or at least nuchal translucency is, which is basically like, this could be something, but also it could just be totally normal. And it could fix itself. It could be not indicative of anything whatsoever, but there are certain conditions that we start to think of. So before I send y'all off to do your Googling, what are some genetic testing options that you're aware of in the second trimester of pregnancy? Has anyone ever heard of like an amnio? Okay. So the 2 options that come to my mind is like specifically second trimester or invasive testing, I guess is what we call it. Options are chorionic villus sampling, which you've probably heard called CVS, and amniocentesis, which is colloquially referred to as amnio. So both of those involve like an ultrasound guided needle going into the pregnancy and taking a sample of something. So CVS takes a sample of the placenta, And amnio takes a sample of the amniotic fluid, which is the fluid that the fetus sits in the pregnancy. There's also testing options like non-invasive prenatal testing, which is a blood test that looks for circulating fetal DNA in the parent's bloodstream. That can be done at any point in pregnancy. So, given we know about an increased nuchal translucency and some sort of generalized kidney anomaly, I'll give you like 3 minutes to do some Googling and figure out what some options for what this could be or what it couldn't be. So take your time. You can turn your camera off if you need to. And I'll see you at like 11:43-ish. Alrighty, y'all. Are we feeling like we've got at least one condition that we could share with the group that you think this could be? Okay, lay them on me. Just shout them out. I'll write them down.
I found that increased nuchal translucency can indicate Down syndrome.
Okay.
And well, other forms of like trisomy.
Yeah, trisomies. Alrighty. Anyone find anything different?
It mentioned congenital effects, like heart abnormalities potentially.
Yeah,
And
like a congenital heart defect.
maybe- That's like we're seeing a kidney abnormality, maybe something with the kidney.
Mm-hmm. That's absolutely right. Anything else? Alrighty. Well, yes, I think increased nuchal translucency, I think the first thing I learned in GC school was Down syndrome has increased nuchal translucency, and so do other trisomies. So trisomy 13 and trisomy 18 are the other trisomies we think of. That just means like 3 chromosomes instead of 2. So let's talk about what happened. Also, this is a case that like a supervisor presented to me with some of the details changed to make it a little bit more clear. So this is real, but this couple declined any kind of quote unquote invasive testing. However, they did want to do non-invasive prenatal testing, which is what I mentioned with the taking the parent's blood and testing that. Will this detect the conditions on your differential? Yes, it will. It will detect chromosomal abnormalities. Might not detect a congenital heart defect, but an ultrasound could do that. Your results come back with sort of chaotic results. You've got a bunch of trisomies. You've got a monosomy, which is 1 chromosome. Like, it seems like almost every chromosome has something going on. So you immediately say you need to get another ultrasound. Like, what's going on here? And both the nuchal translucency and the kidney anomaly are normal now. Like, it's fine. And you find out later on down the road that the child was born at full term without complications. So what was going on here? Because something was going on. Mom had cancer. So what NIPT does is it's looking for small pieces of DNA that have come off of the placenta and are circulating in the blood. But at the same time, tumors do the same thing. So they can shed DNA that can be found in mom's blood. Except cancer has chaotic mutations. There's lots of mutations. That's what makes it grow uncontrollably, right? So what this test actually discovered was not a condition in the fetus, but a condition in the mother who had a subsequent cancer diagnosis that was able to be picked up and treated because of prenatal testing. So I just thought that this was an interesting case example. If you have any other questions about this or want to reach out to me, I'll provide my email in the chat, but I will hand it over to Amanda.
Hey, sorry, let me start my video. Hey, can you guys hear me okay? Yeah, okay. Well, thanks for the great introduction to the field, Maddie. So definitely covered a lot of bases, and I agree with all the stuff you said about some of the things about why you might like the field and the different avenues you can get into in different specialties. I've been practicing for almost 15 years now, so it's changed a lot over time. Salaries are definitely different than they used to be, and the field has grown, number of specialties, all that kind of stuff. So all changing for the better as a career to go into, I can say. So again, I am a Wildcat alum, graduated in 2006. I was a biology major and German minor. So I think it was Daphne, who's also a language minor. So yeah, totally all in on the liberal arts, random German thrown in there too. I've used it once in my career, translating a pathology report that was in German. Anyway, so I went into Davidson wanting to be a bio major. I had no idea what I wanted to do with it, though. I know I didn't want to be a physician or a nurse. I'm just not good at like hands-on. I was worried about hurting people. I'm much better at talking to people. But I liked the idea of going into healthcare. And then my sophomore year, I took a genetics class with Dr. Hale, fell in love with genetics, and again, didn't know what I wanted to do with that information. I'm not a big like working in a lab type person. If I just pipetted things all day, that would, drive me crazy. But just didn't know what to do with it still. My junior year, I studied abroad in Germany. So I had some extra time to kind of do research about kind of my next steps and learned more about genetic counseling as a field, and like kind of that solidified my decision to want to go into it. So I went into my senior year back at Davidson trying to put all my efforts into getting in all my prereqs, like stats class and biochem and basic courses that they do require for most training programs, and also a lot of those clinical experiences or patient experiences trying to make sure I could get those in as well. So I did apply straight out of undergrad, which I do think is less common these days. I think many more people are kind of having some life experience and kind of help build their resume in between. It's gotten more competitive, I can say, to get into grad school since I was applying. But anyway, so I applied to several schools on the East Coast. I ended up going to the program in Manhattan at Mount Sinai. So I really liked my experience there. And then I'm originally from Florida, so I wanted to move back down south and took a job in Atlanta at Emory. Back then, most of the jobs were with academic institutions. So you kind of had to go to a bigger city where there's an academic institution that had genetic counselor roles. That's not the case anymore. There's much more variety in where you can move and the type of work format. So I spent several years at Emory doing all different types of genetics. So I did an adult clinic, cancer, prenatal, preconception. And I also even helped write some lab reports. They would just like throw anything at us. So then I decided to specialize in cancer after a few years, because that's always kind of where my passion was. And then I've, for the past 9 years, been at a community hospital here. I'm still in Atlanta, called Piedmont. And when I started here 9 years ago, I was the sole genetic counselor, kind of took over the role from someone who started the role here. And now I lead a team of 12. There's now 12 of us genetic counselors who all specialize in cancer. So we're a very, very large group. So I started out doing a lot of direct patient care, but now I kind of manage the team of genetic counselors and do kind of a little more operations and processes and that kind of stuff, which I'm really enjoying as well. So that's kind of how I got here. I guess a little bit about what I kind of have liked about genetic counseling. I think originally I wanted to go into the field because when I found kind of the science and genetics of it very kind of intellectually interesting. I liked that I would continue to learn over time. I honestly didn't realize how much I would learn. The field has changed so much so quickly. Like before I retire, it's going to be like a whole nother world. It'll be crazy, but it's good. It's keeps us on our toes and it's very interesting all the time. When I went to grad school in my cancer class, I learned about maybe 10 cancer genes, maybe. And now we're doing panels of like 80 plus cancer genes. So it's just night and day. So I love that. I love working with patients, feeling like you have time to spend with them, can kind of explain things to them, but also kind of provide that psychosocial support as well. And you kind of feel like you're making a difference. I do feel like a lot of what we do is like translating information, making complex things understandable, like Maddie was saying, not just to patients, but also to other members of the healthcare team. I think one thing that I've learned over time is that, I feel like MDs have this, they're like the big people on campus in a hospital, but the physicians that I've had the pleasure of working with very much respect us genetic counselors. Even though we don't have an MD behind our names, they think of us as like the genetics experts. If they're like, I have no idea what this gene is, like, hey, Amanda, tell me what it is. So we do a lot of like provider education because we get a lot more training in genetics than the physicians do. And I think we are well respected for that, which I really appreciate. I also like working like in a multidisciplinary team. It certainly depends on what area you work in, but as a cancer GC, I'm working with other genetic counselors, of course, but I'm working mostly with other oncology folks, so less genetics folks, but like I'm meeting with, surgeons and medical oncologists and radiation oncologists, nurse navigators, oncology social workers, oncology dietitians, operations people, and the physicians areas, OBGYNs and gastroenterologists, like all these different groups. Like Maddie said, we call into tumor boards, and are kind of the genetics experts there, making sure like, hey, this patient hasn't seen us in genetics, you need to place a referral, so because it'll impact them or their family or whatever. So definitely kind of a nice multidisciplinary care team there. And I think there's the traditional kind of roles we do in genetics, like, meeting with the patient and doing risk assessment and education, all that kind of stuff. There's a lot of trickle down effects for then the family members after that as well. And again, a lot of education. But there's also a lot of kind of peripheral things we do too, like community education. I've done grant writing, a bunch of public speaking, developing educational materials, supervising and training genetic counseling students, again, operations and processes. So there's a lot of like things that you can use your skills in other areas of the field, which is cool. And I guess a little bit about why I like cancer genetics. It has become increasingly important in the patient's care. Not that other aspects of genetic counseling aren't important, but as Maddie referenced, like it's in a lot of like oncology accreditation and like guidelines and things like that, genetics is a key part of that, and hospitals are not compliant with it unless they like do proper protocols to get patients to genetics. So I think that's why that's become especially important. Also, the genetics isn't just like, hey, this might be good to know for your family members. It can actually impact that patient's actual treatment. So it's time sensitive, and we don't want delays and all that kind of stuff. So one thing I like about cancer genetics is it's very actionable. We in genetics are usually, we're not meeting people because like to tell them like, hey, everything's perfect and you're healthy. Like people don't come to genetics if everything's fine. Usually there's something going on. So we're often giving challenging news, as Maddie referenced. So there can be some burnout in the field. Lots of tricky conversations over the years can weigh on you over time. So for me, I knew that since the cancer genes, like if there's that risk factor there, we can do something about it. We can impact treatment. We can lower the risk for family members. That kind of positive spin on it for me was something that I knew would help kind of keep me more engaged in the field. And is, even if I'm giving this person news that they don't want to hear, that positive spin, even if it's just in my mind and the patient's not feeling that, that's fine, but it helps kind of keep you in it. But that's my take. A lot of us feel very strongly about the specialties that we work in. So there's definitely people who are like, I would do nothing other than peds. And what Maddie said about the hearing that you can either pick your specialty or where you work, I also heard that graduating. And I think it was like mostly kind of true. I think it just depends on the year and the job market at the time. But you are trained to come out and do everything. Yeah, happy to take any questions, but that's kind of my story and path.
Anyone have any questions?
I can go. Sorry, I have a lot. I've been thinking about this a lot, which is why I have so many questions. I'm sorry if it's a little annoying. But I talked to a genetic counselor over the summer who works for more like a California company, more so than like the hospital side. But she said that one thing that she would have done if she could go back is get her PhD first and then do genetic counseling masters. And I was wondering, because that's a lot of time. And I was wondering if you have any insight into that, or like would say that it disadvantages you at all to not have that then further education, I guess.
I would say it depends what your career goals are. I mean, if you ultimately want to do something that a PhD would be necessary for, then yes. But if your goal is to be a genetic counselor, you absolutely do not need a PhD. I do know a number of genetic counselors who have PhDs, but they're rare. Some of them use it and some of them don't. So it's certainly not necessary unless you want to be someone who's like maybe doing a lot of clinical research. Then kind of that side of things could be beneficial. But if you want to do kind of like, if you want to be a typical genetic counselor, you certainly don't need to do that.
Thank you.
I had a question. I was curious as to how long you work with patients. I know it's going to be different based on what field you're in, but I was wondering if you know per field how long you have that relationship with the patients.
Like how long an individual meeting is, or how long over time you interact with the patient?
Over time,
Yeah.
like years or like weeks.
Yeah, so it very much depends on the discipline. In cancer, a lot of times it's like once or twice maybe, and then like I did honestly have someone who I'd spoken with like 8 years ago just send me a message this week. So there are some people that loop back and maybe we'll talk to their family members over time, but most of the time those are pretty short. Same with prenatal. Peds, I think you could see them recurring over years depending on the clinic. I know I have a close friend who worked in one of the rare disease areas, lysosomal storage diseases, and she like knew those families in and out. So they had a very, very intimate relationship and long term. But I'd say most of the time it's kind of shorter interactions. Maddie, feel free to jump in if you have other thoughts.
Yeah, I just put in the chat, in the pediatric clinic I was in Greensboro, depending on the patient, we would see them every 6 months or every year just for sort of a check-in. If they're on like a clinical trial, we'd often see them more frequently than that. But I think it is really heavily dependent on specialty.
Just tagging on to the question earlier about kind of getting experience, I know that can definitely be a challenge. And I think Maddie's answer was perfect. I think being able to talk about it is key. And I would just say, like, do your research about the field, even if you can't get all those experiences. I think if you show up and like you haven't read about what a genetic counselor is and like showed some effort, you are not going to get in. Also be prepared to answer like why are you going into this? Like one of my interview questions I remember back in the day was like, why aren't you applying to med school? Like you have the grades, why aren't you applying to med school? Because that's like an obvious path. And so like, and I wasn't ready to answer that question. I knew my personal reasons, but like those kind of things is like, why did you choose this path? Because they want to make sure like if they're investing in you in this competitive to get into field, like that you've thought about it and this is what you want to do. And I can't say there's many like state genetic counselor organizations, like, in Georgia, we have like the Genetic Association or Georgia Association of Genetic Counselors, and I'm sure it's other states, like I'm sure there's one in North Carolina, where there might be like an annual education meeting and like you can probably get invited to it. I know we've had prospective students like show up to the education meetings. That's a great experience. You get to like network with people, learn some things. So don't hesitate to like reach out to some of those local groups. Also, genetic counseling assistant jobs are like a often kind of common way to get into the field. It's seemingly almost a guarantee of getting into grad school, but maybe not 100%, but it definitely gets you really relevant experience. But those jobs are really competitive is my understanding. I know we don't have GCA jobs, but I can say over the years, we've had a couple people who wanted to be a genetic counselor and I couldn't pay them, but they were like, hey, could I volunteer? So they applied to be a volunteer through our hospital, and like maybe they worked a side job over the summer, and they came and volunteered with us, and we're basically doing genetic counselor assistant roles and got like really cool experience without there being an official role. Now that's not doable for everyone because again, volunteering is not paid, but if you have the flexibility to like maybe do a summer job doing something else and like volunteer at a clinic, that is potentially an option. Also, some of the labs have internship programs for prospective students too.
And what would they look for? What would students look for to find those lab jobs? Would it have the genetic counseling in the title, or?
Yeah, genetic counseling assistant, or GCA, is usually the term if it's like through a hospital and maybe some of the labs. But I think it's like, I think Color, Maddie, you probably know this better than I, Color has some internship opportunities, particularly for people of color, I think, because there's kind of a lack of diversity in the field. I don't know if any of I want to say GeneDx, I might have heard, has something.
Yeah, I know GeneDx has GCAs. I was also going to mention some of the GCA jobs will have some sort of like they're targeted towards people who are applying to school and will have like resume and CV development built in. So UNC hires 3 GCAs every year. It's a 1-year position, but they all of genetic counselors there will review all of your application materials and help you prepare for interviews, do mock interviews. So if you can find a place that like is built for that, that can be really, really helpful too.
Yeah. So the Matthews Center, just to make a plug for that, the Matthews Center does offer a lot of mock interview prep and application assistance, of course, as well, to supplement that. Okay.
Yeah. And UNCG is having a resume boot camp next week virtually, I think, where you can sign up for a 15-minute slot and our program director will review your application materials.
Okay. All right. Excellent. Well, I try to start and end on time. I see we're just a few minutes over. I appreciate, Maddie, thank you for putting your email in the chat and making yourself available as a resource. I really appreciate that. And thank you for both of you for your time. There's no better advocate for the field than someone who's been in it, Amanda, for a number of years, and someone who is committed to pursuing this path in a graduate program. So thank you again to both of you for being willing to talk to our students.
And I put my email in there as well. So we get a lot of prospective student requests through our teams. We've had to kind of triage them, but and right now we only have shadowing opportunities if someone either lives in or goes to school in Georgia. But at least if you wanted to participate in like a Q&A session with one of our genetic counselors, it would probably be one of the younger ones who's been through the process more recently than I am. We'd be happy to have any of you for that if you wanted some extra time with Q&As. So someone who's probably graduated in the past 3 years. So if you would be interested in that, feel free to shoot me an email and I can get you signed up for that too.
Super kind. Thank you very much. Thank you. All right, students, I have a note drafted. You'll get the emails in just a few minutes, but thank you again to everyone. Thank you for participating. Thank you. We really appreciate it. All right, take care.
Good luck.
Yeah.
Thank you.
Bye. Thank you, guys. I feel like I've said thank you so many times, but I really do. We know we haven't done something like this that I'm aware of. And so I think it's awesome. And the fact that all 7 students, well, we had 9 registered, but 7 showed up, and I'll be sending materials and sending them. I forgot to ask you if recording you was all right. Is that okay? Okay. All right. I could throw it away if you don't want it going out, but it could live on our Matthews Center resources page, just as students are considering the field. So, okay. Well, thanks.
Can I ask a favor?
Yeah.
I have a 4-question evaluation form. Is there any chance that could be included in whatever message you send out to the students?
Yeah. Will you email it to me? And I will wait to hit send on my note until I get it to tuck it in.
Thank you so much.
Of course.
You did a great job, Maddie.
Yeah, you really did.
Thank you. I love doing this kind of thing.
Yeah, you're a natural teacher, so you're in the right role. Excellent. Well, thanks again. All right. Have a great day. Okay.
Take care.
Bye.